Welcome to Bench to Bedside, a weekly series of live conversations about recent advances in cancer, from the research bench to treatment at the patient's bedside. And now, your host and the director of the University of Kansas Cancer Center, Dr. Roy JENSEN.
Welcome to Bench to Bedside. Today we're talking about metastatic breast cancer, as well as the latest available treatments and ongoing research aimed at improving patient quality of life. With me today is Dr. Priyanka Sharma, a breast oncologist and clinical researcher, and Dr. Danny Welch, a researcher specializing in cancer metastasis. First of all, thank you for joining us today on Bench to Bedside. Can you explain to us, Dr. Sharma, what it means when breast cancer metastasizes?
So for any cancer, when we say it has metastasized, it means that the cancer has landed in an organ outside of its primary origin. So if breast cancer cells settle in bone, it's called metastasis of breast cancer to the bone. It's still not bone cancer, it's breast cancer because that's the primary source. And various cancers can metastasize to different parts of the body.
Dr. Sharma, are there factors like breast cancer subtype that put you at greater risk for metastasis?
Certainly, different breast cancer subtypes have different propensity of metastasizing. For example, triple-negative breast cancer is the highest risk of metastasizing, especially the ones that don't respond to preoperative chemotherapy. Among hormone-positive breast cancers, the ones that categorize into higher genomic risks also have a higher risk of metastasizing. And of course, our conventional staging factors like lymph node involvement and size also play a role in risk of metastasizing. Cancers that have multiple lymph nodes that are involved at the outset have much higher risk of metastasizing.
And Dr. Welch, did you want to weigh in there?
I was just going to add that different types of breast cancer can go to different organs. So hormone receptor positive breast cancers most commonly go to bone. They can go anywhere, but triple negative goes everywhere a lot more frequently. So different types of cancer have different patterns of where they spread.
Different homing organs that they like
Exactly.
to attach to.
Mm-hmm. So Dr. Sharma, what kind of treatments are available for women who are diagnosed or discovered to have metastatic breast cancer?
So we have a wide variety of treatment options available for women with metastatic breast cancer, and often the treatment choices are based on the subtype of breast cancer and the extent of spread. For hormone-positive breast cancer, there are multiple types of anti-estrogen or anti-hormone therapies, targeted drugs like CDK4/6 inhibitors or mTOR inhibitors that can be combined with endocrine therapy. There are different types of chemotherapy agents. There's several HER2 targeted drugs that are available. For women with BRCA 1 or 2 mutation-associated breast cancers, now we have PARP inhibitors that are available to use, and also there's emerging data on the activity of immune therapy, especially for a subgroup of patients with triple-negative breast cancer. In addition to this, there are clinical trials that are available that are often offering newer treatment options for women.
Okay. So if you're just joining us, we're with Dr. Priyanka Sharma and Dr. Danny Welch, and we're talking about metastatic breast cancer. Remember to share this link with people you think might benefit from our discussion. Use the hashtag #BenchToBedside. So, Dr. Sharma, what questions for a patient who's diagnosed with metastatic breast cancer, what should they be asking? What are the key things they need to know?
So they should ask their providers about the subtype of breast cancer that they have, because that definitely determines treatment options and the spread of disease. Beyond that, discuss the available treatment options and the side effects, because that's an important decision to determine what fits the best for an individual patient. The recommendations that we make for a patient should fit their goals for the treatment. And I always encourage my patients with metastatic breast cancer to ask for availability of clinical trials, because that's how you get access to newer and sometimes better treatment options.
So what is the importance of when a patient's in that situation of getting a second opinion, you feel?
I think it's very important. Number one, to be certain of your diagnosis and the type of breast cancer you have, and to come up with the right treatment plan that best fits that individual's need. You know, different individuals have different expertise, different institutions have different things that they can offer to the patients, and it's just a matter of finding the right fit for an individual. Also, different institutions and places might have access to different types of trials, and based on the need of that individual patient, one place might be a better fit. Mm-hmm. I personally am never hesitant if my patients want to get a second opinion. If anything, I think it helps us improve care.
Right. Well, I totally agree with that, and I think physicians that are afraid of getting a second opinion are probably afraid of their first opinion, is the way I like to put it. So Dr. Welch, it's, we've certainly seen a lot of advances over the course of our career, and more and more patients are surviving and living with metastatic breast cancer. What do you attribute that phenomenon to?
Well, it's tough to assign a particular reason that people are surviving longer, but I think earlier diagnosis is helping a lot. Improved surgical techniques, a bigger repertoire of chemotherapy agents, and even though the immune therapies are not working as well in breast cancer right now as they're looking like they might, there are a lot more options for breast cancer physicians to treat patients. I like to think that the research that's gone on in the laboratory, even though people like myself are treating rats or mice that have breast cancer, a lot of the things that we've learned in the laboratory are translating in practical ways for physicians to modify how they're attacking the breast cancer. Mm-hmm. So there are a lot of things that go into it. And I think a nice way to illustrate the progress that's been made, when I was studying as a graduate student, the statistics were that no woman with stage 4 or metastatic breast cancer lived 5 years. I personally now know probably 30 or 40 women who are 20 years out with metastatic disease. Mm-hmm. It's still a struggle. They are not cured, but they're alive and they're having a reasonably good quality of life. That's a big, big advance.
And I think it's true team science, as Dr. Welch noted, that the information that we gather about the biological heterogeneity of the disease from the lab is now translating into better drug development and better treatment options for patients. You know, a prime example is HER2-positive breast cancer, where the natural history of disease has really changed over the last 15 years once we understood that targeting the overexpression of HER2 leads to better treatment. And now we have several drugs that are available in clinic and several more that are in clinical studies.
Right. You mentioned the word heterogeneity, and I would say one of the most important reasons why we've made so much progress against breast cancer. And when I started my career, 5-year survival for all comers in breast cancer was probably 75%. And now it's well over 90%. And Dr. Welch talked about a number of reasons, earlier diagnosis and that thing. But I think a big reason is the recognition of heterogeneity and the development of tailored and targeted therapy for HER2-neu, for endocrine positive disease, and it's just been absolutely critical to get over the idea that you treat all breast cancers the same. They're not the same. They're biologically different, and recognizing that and then specifying your therapy based on those differences is absolutely critical.
I don't want to make this sound like a negative thing, but heterogeneity is probably one of the most challenging aspects of any cancer, be it breast or any other cancer. Mm-hmm. Because what most people don't know is that the smallest tumor we routinely diagnose is 1 billion cells. And of that billion, it's thousands of different subpopulations. Some are sensitive, some are resistant to therapy, and it just makes the task of eliminating all cells all the more challenging. Some will metastasize, some won't. So while we have different kinds of breast cancer, we also have different kinds of cells within each tumor. And there will never be a cure for cancer because we're not treating one thing. Even with one tumor, we're not treating one thing.
So you're known really all over the world for research into metastasis and breast cancer is certainly one of your major areas. And so, the biology of breast cancer has been an evolving field over the last few years. What kind of research is taking place that really focuses on improving the quality of life for our patients and not just an investigation into the biology?
Well, there's a new funding mechanism that came with the approval of the Affordable Care Act. And it's the acronym is PCORI, Patient-Centered Outcomes Research Institute. And there's an entire arm of research that's going on to address what patients see as their particular needs. 15, 20 years ago, Dr. Sharma wouldn't have said there's no such thing as chemo brain. The aspect of after chemotherapy, there are issues with remembering things, finding words, all sorts of things. But in the last 6-8 months, there are actually a few papers that have come out that are seeing a chemical reason for what is euphemistically called chemo brain. There are a number of other things that I've seen come up in the last few years, looking at the genetics. The underlying genetics, even though that's the biology that you talk about, help address why, for example, African American women develop what's known as triple negative breast cancer at a very high frequency, percentage-wise, than Caucasian or Asian women. And there is evidence that there are genetic reasons underlying that, and that affects what they get, but also how they're being treated. And I think Dr. Sharma's the world's expert on triple negative and can address that
So in
better.
terms of quality of life, what also we're seeing now is a lot of our now phase 3 studies for registration trials of new drugs include quality of life as one of their key endpoints. So it's not just important to show drug A plus B is better than B. One has to keep in mind the toxicities the addition of B brings upon, and is that something that's palatable to our patients. In addition to that, a lot of our big trials are now including patient-reported outcomes as one of their key secondary measures. And engagement of patient advocates in our trial design is a key element now for all big trials. So with all of this, we're understanding that just showing efficacy is one part of the coin, but we've got to maintain the quality of life as we do that, because as we just said, these patients are living longer and longer. So maintaining quality of life and allowing them to be able to do and enjoy things they like to do is very important.
And as you mentioned, advocates, the involvement of advocates both in the clinical but also in the laboratory has been really critical to educating people. Metastatic patients who have metastatic disease now have support groups and teams of people who are not just their caregivers, but their entire families. Their quality of life improves because everybody's better educated, and the options, again, get greater because of that.
Well, I'm really glad you mentioned the advocates, because when I began my career, basically every woman with breast cancer had a radical mastectomy and was given the same type of chemotherapy. And it didn't matter what type of breast cancer you had. It didn't matter what stage it was or anything else. It was like, we have one treatment, you're going to get that treatment, and you're going to like it. And I think it was really because of the advocates who pushed back on that and said, this is not acceptable.
Right.
And you guys, and at that time it was mostly guys who were driving these treatment decisions, need to do better. You need to listen to us, and this is not an acceptable situation. And it forever changed the landscape. And I can think back, and no doubt a critical event in all of this was when Betty Ford was diagnosed with breast cancer. And that was an absolute game changer because she decided to, not hide her diagnosis. It wasn't that, long before when she was diagnosed, when basically many women felt like this was something they had to hide. And they didn't want to talk about their treatment. They didn't want to talk anything about it. And she brought it out into the open and encouraged us to make an issue out of it and say, this is not right, and we have to do better. And I give her a huge amount of credit for, it took a lot of bravery. At this point, everybody's kind of, well, yeah, why wouldn't you do that? But believe me, that wasn't how it was.
Cancer was the C word, talked about only with a few people. And in many ways, having metastatic cancer in 2019 is the M word. Many patients are marginalized by their employers, insurance companies, and even friends fear talking to them because they don't want to say the wrong thing, because metastatic often means dying.
Right.
And now that people are living longer, it's becoming a little less hidden. It's more mainstream, like Betty Ford's breast cancer diagnosis.
Well, I think certainly back in the 1970s, when if a woman was diagnosed with metastatic cancer, it was kind of close the book. Right. We're done. We have nothing else to offer you. Go home and make the most of whatever months are left in your life. And we're a long, long way from that now. So, Dr. Sharma, what would be your advice if a woman is suddenly diagnosed with metastatic breast cancer? What should they do?
I think I would tell that women that we now have numerous more options to treat that cancer than we did 20 years ago, and the outlook is so much better with several new drugs that are on the horizon and in clinical trials. She should learn about her cancer, understand the type of cancer she has, and understand the treatment options available. And as I said, now we're in this era where we're not just saying you will take this treatment. We will say, well, we have these 3 options. Let's go over the pros and cons and the side effects and the impact on quality of life. And let's go over the goals of therapy for you as an individual sitting in front of me, and make the right choice, knowing that once this stops working, we will have other treatments to discuss and talk about. And I personally have several patients with metastatic disease that saw their kids complete college, get married, have grandkids while still living with metastatic disease and moving from one treatment to another treatment. Of course, the story is not the same for everybody. That's what our hope is for future. But it is much better than what it was 20 years ago.
Yeah. Go ahead.
You said something, and I know it was inadvertent, but you said she. And it's important for people to know men also get breast cancer. And that's one of the issues that was emphasized to me at this PCORI conference that I participated in. There were 5 or 6 men there who have metastatic breast cancer. And it's important that we recognize it's everyone involved. And
the treatment options are as wide for men with breast cancer as they are for women with breast cancer. And there's special efforts to study the biology of
and I
breast
think
cancer.
my raising that point was to show that I'm being educated by the patients and the advocates as well. Sometimes it's the little things not to be ignored as a patient. The males felt like they were ignored. They were never treated in Kansas. That's the important part.
So could you tell us a little bit about the Women's Cancer Center that we just opened? And maybe use that as a platform to discuss what are all the components that you think a woman ought to have at her disposal in terms of the comprehensive services that go into making up a really premier breast cancer program.
I think it's very vital to have a multidisciplinary team, because it's a team approach that provides expertise from a medical oncologist, provides expertise from a surgeon and a radiation oncologist, and provides expertise in terms of cancer psychology, cancer genetics, because these all are important aspects of delivering the best and the personalized care to our patients. Also, as patients advance through their metastatic course and run through the first few lines of treatments, I think it's also important to be able to have access to a phase 1 unit where you can get information on newer phase 1 trials if you wish to go in that direction. And what we've done here is we've always had this multidisciplinary focus where based on the patient's need, the patient is seen by every discipline that needs to play a role in their care. Mm-hmm. For patients with early stage disease, it's surgeon, the radiation oncologist, cancer genetics if that is needed, financial counselor, social services if we need to arrange for their travel or overnight stay for treatments for patients with metastatic disease. The team is slightly different, but the important concept is to have a team approach where all the individuals that are part of the team communicate with each other and do so with the sole focus of providing the person the best care.
I'm going to add one thing to your list, pathology.
Yes, yes, because that's where you get the right diagnosis.
That's
so
right.
If you have an error in the pathology read, that will impact every decision down from there.
You might want to address the issue of specialization even in pathology.
Oh,
breast pathology
Yes.
is not the same as GI pathology
Right.
and that type of thing.
Right, yeah. Most of my early career was spent doing breast pathology, and I had the luxury of and the privilege of really training with what I consider to be the best breast pathologist of all time, that's David Page. And he really helped define the field, and it's just so important to making sure you get that diagnosis right, because all of the heterogeneity issues that have arisen with breast cancer over the last 20 years, it's you have to make that call correctly, or else you're going down the wrong path. So
It's the difference between seeing tens of slides versus thousands of slides.
yeah, we in my time with David, we literally saw almost 70,000 cases, and there's no substitute for that amount of experience. The other thing that I would add to that is a comprehensive program of prostheses and an appearance center. Many therapeutic options that are available to breast cancer patients. They're going to lose their hair, and that is critically important. In fact, when you talk to patients, that's one of the things that they complain about most.
And breast reconstruction,
Yes.
to have options available for women that want to avail those options, regardless of the type of surgery they would need or radiation or not, to have options available to have reconstruction. I think that's also increasingly important because that's part of the whole care. It's not just taking the tumor out, it's healing the patient from one end to another end,
Right.
so they can continue on with their life.
So for the last several years, by far and away, we have treated more patients with breast cancer at the KU Cancer Center than any other type. And we treat well over 1,000 patients a year. And one of the things that does is it affords us the luxury of being able to specialize in this area. And in fact, while you treat a variety of different types of breast cancer, your specialty is really triple negative breast cancer, and you're a world-renowned expert in that regard, and you've built one of the largest registries in the world for that disease, and we've really done some wonderful things in terms of designing clinical trials, really understanding triple-negative breast cancer at a molecular level, understanding the response to therapy, and you just can't do that when you're treating 15, 20 cases a year.
And then I would add to that out of those 1,000 patients, at our center, a quarter of them have opted to go on clinical trials, which means that we've have the menu of trials available for women if they do want to explore different treatment options. And I think that's an opportunity I feel like no cancer patient with a new diagnosis of cancer should miss.
Absolutely.
So, since you've mentioned clinical trials, in talking with several patients, not as many as either of you, but one of the fears that a lot of people have is that clinical trials means we're experimenting on people and trying to do things to them that are not the best care possible. And I think it's just important to emphasize every patient gets standard of care, and clinical trial is to try something new, to offer new options. And I think making that definition is absolutely critical, especially for the metastatic patient.
And in this era where it used to be where you would opt for clinical trial once you've exhausted every available option in clinic. But in this era now, newer and better drugs are moving on earlier in the space in the metastatic disease. So if one would wait till the end of clinically available options, sometimes there's no trial available. Just a prime example for, as you said, immune therapy is new to the world of breast cancer, and it is now showing efficacy in women with triple-negative breast cancer. So the randomized phase 3 registration trial for immune therapy in triple-negative breast cancer was done in newly diagnosed patients with metastatic disease, where patients receive standard of care chemotherapy with or without the immune therapy drug. So that's newly diagnosed women, not later down the line. And the women who got immune therapy in combination with chemotherapy, if they had a particular marker expressed on the tumor cells, their overall survival was doubled. So that's a prime example of where now our trials are moving earlier in the course of disease, and for good reasons.
Mm-hmm. Well, thank you so much, to both you, Dr. Sharma, and you, Dr. Welch. That's it for today. Tune in next Wednesday at 10 a.m. for our next episode of Bench to Bedside.